Hafa everyone. Welcome to the Guam Congress Building. The Committee on Health, Land, Justice, and Culture is now called to order. Today's Thursday, September 28, 2023. The time is about 2:10 p.m. In compliance with the Open Government Law, notice for this public hearing was published in the Guam Daily Post and posted to the Government of Guam Public Notice Portal on Thursday, September 21st and Tuesday, September 26th. Notices were also sent by email to all senators and all main media broadcasting outlets. This hearing is being live streamed on the Guam Legislature's YouTube channel. This is an oversight hearing, so there's a couple rules of conduct I'd like to enforce. Individuals testifying shall first be recognized by the chair before speaking and begin by stating their name for record-keeping purposes. In an effort to minimize distractions while someone is testifying, the committee asks those present to please be quiet and refrain from moving around within the public hearing room. Additionally, we've asked protocol to keep the doors quiet when they are opening and closing. Individuals who are presenting oral testimony are invited to submit written testimony afterwards in order to ensure that your input is accurately transcribed. We are transcribing these proceedings, and sometimes it's hard to hear. After testifying, panelists will only be allowed to speak again in direct response to questioning or invitation of a senator who has the floor, or at the discretion of the committee chair. After all have testified, senators will be recognized for questioning of the panel or comments and shall not interrupt any other senators. I'm asking senators to keep their questions to 5 minutes for at least one round, and then we'll go back for other rounds if necessary. This hearing is to collect testimony, not to debate or to engage in back and forth arguments with the participants. Berating of any of the witnesses will not be allowed. If you ask a question, please allow them to answer. And participants, please answer as directly as you can. Again, our agenda item today is an oversight of the Guam Memorial Hospital Authority. I'd like to acknowledge the presence of my colleagues here today, beginning with the Vice Chair of the Committee on Health, Senator Joanne Brown, Senator Terlaje, Senator Tom Fisher, Senator Chris Duenas, Senator Frank Blas Jr., and Senator Joe Salagstein. Thank you, colleagues, for being here. I want to thank all of you from GMH who are here today. We particularly invited the Guam Memorial Hospital Authority management team to participate in this oversight hearing. Our notice on this oversight said it was an oversight of the Guam Memorial Hospital Authority to address community concerns, including billing backlog, maintenance and repair of the HVAC and other facility issues, patient care, status of previous appropriations for the hiring of specialists, renovation of labor and delivery ward, and other capital improvements. So today's oversight is due to concerns that our committee has received from the public and concerns that were raised during budget hearings and the budget session regarding billing, backlog, the HVAC systems, of course, and other facility issues that we've seen over the years and that continue to plague the Guam Memorial Hospital, patient care issues, and the status of these previous appropriations for specialists, renovation of the labor and delivery ward, and other capital improvement projects. One of these capital improvement projects is the EHR system, Electronic Health Record System, and we will talk about that. It's the hope of this oversight. I mean, we know there are overwhelming problems right now at GMH, and there's a lot of hard work also at GMH. And maybe, you know, some of us are frustrated or emotional, so I'm trying to keep it as streamlined as possible, as efficient as possible under the circumstances. We want answers and we want solutions. So we want to see if there are any other solutions that are being considered, and we want to, you know, be able to make decisions as well that are informed and make sure that the public is informed as well. In the 34th Guam Legislature, we discussed the GMH's need for a new EHR. This is an electronic health record system, repair of the labor and delivery ward, the HVAC, and many other things. in Public Law 34-116, which was the budget bill for FY 2019, they appropriated $600,000 from the general fund to GMH to pay for principal, interest, and debt service reserve deposits for the GMHA labor and delivery ward renovations for fiscal year 2019. In the 35th Guam Legislature, in its budget hearing, GMH requested zero in for capital improvement projects. And in that fiscal year 2020 budget and the fiscal year 2021 budget, the legislature appropriated $10 million to the hospital for capital improvement fund, which to this date GMH has not received and not been able to use for capital improvement projects despite the appropriation. In April 2020, the Army Corps of Engineers conducted a facilities condition assessment of the Guam Memorial Hospital and stated, quote, GMH will require $21 million immediately for repairs to support the reaccreditation of the facility and eliminate hazards to life, health, and safety. These repairs and fire sprinkler repairs, the options below are proposed for end state facilities infrastructure capital investment. Sorry, ignore that last sentence. So this was for their immediate needs, it needed $21 million, and all the other options that the Army Corps presented was for the future, either to renovate the hospital or to build a new hospital. In the 36th Guam Legislature, in Public Law 36-107, that was for fiscal year 2023, GMH was authorized $5 million, an additional $5 million to hire specialty care specialists, and $15 million to the hospital capital improvement fund for the labor and delivery ward renovation. These are just some of the efforts by the finance chair and the rest of the committee and the senators of the legislature. And of course, none of these meet the list of capital improvement projects that GMH has compiled. We have seen these records. In November 21, it was estimated that the HVAC system upgrade was going to cost $6 million, would be funded by the Department of Interior, CIP funds, and CARES Act funds. In the budget hearing in July 2023, GMH reported its gross revenues at $156.5 million, which at that time was $100 million less than the previous fiscal year. Of course, the fiscal year was not completed, so we're hoping to get an update on this, and that was attributed to bad debt and the need for additional billing, a backlog in billing. Part of that was explained as due to the system shutdown in October and the new EHR implementation. So we have asked that they provide updates on this billing backlog and on outstanding vendor payments, which at the budget session was reported at that time to be, that was in August. Sorry, our session was in July, and at that time the vendor backlog was estimated at $30 million. An update on the electronic health records and billing, because I think it's the transfer to this electronic health record system that is complicating our billing. And it's my understanding, these are all related, that we may be even at risk of the vendor, not paying the vendor for the EHR system. We talked about the vendor issue contributing to a lack of supplies or a lack of the ideal supplies that GMH might want or need. And we continue to receive complaints regarding patient care, regarding mold, regarding the heat because of the lack of air conditioning. We received this from staff, we received this from patients, and I know all of my colleagues have, many of them have been in the news as well talking about similar issues. We have had some good news from GMH, so I'm looking forward to hearing a little bit more regarding specialists and the hiring of some specialists. We want to follow up on the hiring of any others. All right. I know GMH has prepared a presentation for us, hopefully to update us on some of these issues, and then we will receive any other testimony after this PowerPoint presentation, and then questions, of course, from the senatorial panel. Did I recognize everyone? I think Senator Roy Kanata is also here. Thank you, Senator. Yes, all right. Please proceed. Oh, maybe Lillian, CEO, if you could introduce your team.
Yes, I certainly will introduce our team, but I wanted to just do an introductory opening statement, if okay with you, Speaker. Buenas Hafide, Speaker Therese Terlaje, Chairwoman of the Committee on Health, Land, Justice, and Culture, and all the senators who are here. On behalf of the Board of Trustees, management, medical staff, employees, and the patients we service, we extend our gratitude for giving us the opportunity to update this legislative leadership and to engage in a constructive, deliberative, and meaningful dialogue regarding the many concerns and issues that the public bring to your attention. As the hospital administrator, I, as well as all the respective leaders of our Executive Management Council, we are also very concerned, and we address these matters as immediately as possible given the availability of resources. We take these concerns and issues to heart, and with a determined spirit, we continue to carry out our duties and responsibilities to keep our one and only public hospital operational, premised on our mission statement, and that is, Guam Memorial Hospital is a public hospital entrusted to improve the health and wellness of the people of Guam. We do this by providing an exceptional patient experience centered on quality-driven, safe, cost-effective healthcare services. This is the mission that we embrace, and we expect the community to hold our GMH leadership and management accountable and responsible to deliver. With that, I'd like then to introduce our executive management team. To my left is Yuka Hichanova, who is our CFO. To her left is Dr. Dustin Prince, who is the Associate Administrator of Clinical Services and Acting Associate Administrator of Medical Services. To my right is Mr. William Kando, who is the Associate Administrator of Operations. And we do have some team also some other members of our executive team. We have Ms. Bel Rada, who is the Assistant Administrator of Professional Support. Ms. Lizelle Concepcion, she's the Deputy Nursing Director. And we have several staff who are here to support us and to hopefully, maybe if you have questions, they can answer. Not all of our executive leaders are here in person, but if I may take a few minutes, I'd like to recognize them as they contribute resolutely and significantly to the daily efficacy of the hospital's operations. Ms. Danielle Manglonia, she is the Administrator of Quality, Patient Safety, and Regulatory Compliance. Dr. Vincent Duenas, the SNF Medical Director. Pauline Lizama, she is the Nursing Manager for the Department of Corrections on-site clinics. And Christine Tucaro, she is the Assistant Nursing Administrator, who's not here right now because I think she's got something going on with a hearing. And then Mr. Jeffrey Ventura, who is the Deputy Assistant of Operations. And as requested and published in compliance with the Open Government Law, we will focus...
Sorry, Lillian, I can't hear you anymore. Yeah, try again.
Okay, I guess I need to just be kissing this microphone here. Sorry. As requested and published in compliance with the Open Government Law, we will focus our discussion and presentation on the following issues. And so whoever's got the control of the slide, PowerPoint, we can go into the slide number 2. Okay, is that better? Okay. So the issues and the updates for this oversight hearing will focus on 4 major areas, and one of them is the first one is the clinical services patient care, which speaker you mentioned. And under that grouping, we've got the ER admissions and census, just to provide you with some of the data, the acute care, and what we call community social cases that we accommodate at the hospital. the SNF, which is our skilled nursing facility, AKA our long-term care facility, and then also touching on the outpatient services that we provide. The second major update will focus on our finances, our fiscal updates, and that's on the accounts payable, billings and collections, the previous appropriations for recruitment of medical specialists. The third major category of our issues and updates will be focused on the CIPs, facility and information technology updates, and that will then include the completed CIPs, AC, the aircon that you mentioned earlier. All of these you mentioned, the chiller and the HVAC maintenance and repairs, the labor and delivery / maternal child health renovations and other CIPs, and of course the EHR, our electronic health record update. And then the fourth major bullet is then our staffing situation, staffing updates, which we will focus primarily on the doctors and the nurses, because those are our really difficult professions and classifications of positions that's hard for us to recruit and also retain. So we will begin with the next slide. And I'll have Dr. Prince speak on it in terms of the emergency room admissions and census.
So good afternoon, Madam Speaker and Senators of the 37th Guam Legislature. It is with humble honor that I say thank you. I, for one, am very humble to be sitting here speaking to you all, but also having all wonderful, outstanding colleagues behind me as well as it's a major, overwhelming burden being a leader in our only public acute care hospital, that our people deserve utmost quality care each and every time. So in regards to this first slide, it is talking about the ER admissions and census from 2022 and 2023. What I want to just make mention, number one, is our census keeps on fluctuating. However, it stays at a certain level at all times. In regards to, I just want to make mention, in regards to the admissions, approximately 25 to 27% of everybody that comes into the emergency room gets admitted. So 1 out of every 4. Number 2, I want to make mention is the peds. Our pediatric visits range from 21 to 36%. 36% usually happens within the September through November timeframe, and even in the beginning of the year in January, February, due to various viruses that come about that affects our pediatric population at most. Next slide. In regards to this acute care and long-term social cases, our acute care inpatient census ranges from 144 to 161 on average. Social cases is a big deal for us. Guam Medical Hospital, which is, Guam Memorial Hospital and the SNF, about 20 per month. And in May was a cost balance of 6.9 million, June 9.9 million, July 8.1 million, August was even 9.8 million. There is a policy for custodial care. Custodial care means when the patient does not meet the criteria for either acute care and or long-term post-acute care. In regards to these custodial care patients, again, I want to make mention of our great staff we have within the social services and in the case management and in their departments. For allowing me to talk about these numbers. Ages from 41 to 88 years old. Ethnicities range from our own local Chamorro, Filipino, Caucasian, and Japanese and Korean. There are even 2 veterans. However, they cannot avail to federal resources due to various legal reasons. Majority have no income. 30% are homeless. 50% have a caregiver problem. And 28% have GURA issues. Possible solutions, I'm always about trying to find possible solutions, truthfully, with what we have. There is an administrative initiative for a health task force to establish a long-term care, transitional care solution. There are what is considered right now a whiteboard meeting, which is behavioral health, public health, as well as GMH. We have even spoken about with the Lieutenant Governor and the Deputy Chief of Staff about even possibly thinking within the skilled nursing unit with some of the availability of the real estate there, but it needs a business plan from CMS because the patients who would be residing there are not beneficiaries. There are other possible solutions within for the community, which is truthfully getting more one-bedroom ADA compliant locations within the GURA solutions. Next slide. I just also want to make mention, I'm sorry, on that previous slide, you do not need to turn to it, but I just want to make mention that we are very, very blessed to be able to partner with God's Grace Home in Manila, Philippines as well. One other solution I want to make mention, and I don't want to lose sight of that, is a paid caregiver program within the government paid by Medicaid services. This is actually a great opportunity. It is seen in Hawaii and in California. Just a potential solution. In regards to this slide, I just want to talk about the skilled nursing unit in regards to the license capacity is at 40 beds. However, as Speaker Terlaje has already mentioned, our staffing shortage of nurses, right now we're at 20 beds. We would love to increase current capacity because the SNU is really critical to decompress GMHA acute care beds. I cannot begin to explain to you the taxing service that our nurses and our support staff have in taking care of our custodial cases day in and day out, and it is extremely taxing. With the impacting of services, this could actually then decompress open beds for the acute care patients waiting at the emergency room, for which I am so grateful to our emergency room, the nurses and the physicians and the support staff, in which we have ER holdings in always, most of the time up into the teens and even into the 20s at times. Our nursing shortage really affects the GMHA staff bed capacity. So I would love to then have public health help us and really get a coalition of an opportunity to actually really look at how we can decompress our social cases within our even using our skilled nursing unit. Next slide. I came to the island approximately 7 years ago with my wife and our 3 kids. Now we have 6 children. And I just want to say that honestly, the professional support services led by Sibel Rada, as well as the team, it has really taken off. We now have a cardiology, we have a foot and ankle clinic, interventional radiology, treatment procedures, laboratory services, pulmonary clinic, and then the new service gastrointestinal clinic, rehabilitation therapies, including cardiac rehab, occupational therapy, physical therapy, speech and language therapy, and then the respiratory services. Our challenges with these are, however, and I can be definitely aware of this as I am in there, as a physician, is replenishing supplies. But we are always doing needs assessment for new services. Next slide. I want to make mention of that Public Law 36-107, Chapter 12, the previous appropriations for the $5 million. I just want to say thank you to you all. Please, thank you so much from the bottom of our hearts, as well as to DOA, to the BBMR, and it truly has already helped us in regarding getting our requisitions for our gastroenterology service, operating room, radiology, and the special services. The additional specialty medical and surgical equipment for medical specialists, as what was described, the anesthesia machines, arthroscopy and precision fluoroscopy systems, modular orthopedic and spinal surgery tables, gastroenterology scopes, as well as general scopes, and then even ultrasounds. So thank you for that. Next slide.
as Dr. Prince said, thank you so much for the appropriation under the Public Law 36-107. The $15 million appropriation is going to be based again on the excess of the fiscal year 2022 audit. And so that $15 million, we will then, we propose to use it for an upgrade on our electronic health record system and the maternal child health L&D upgrades, and as well as the main electrical distribution panel. And you mentioned earlier, Speaker Terlaje, that Public Law 35-73 that was approved in February 2020, the $10 million appropriation, unfortunately, we never got that funding. So we can close that book there. And on the next slide, with billings and collections, I will now have Yuka, our CFO, speak more on it.
Good afternoon, Senators. Speaker Terlaje, thank you for having us. I'll speak on the billings and collections and give you an update. So far, as of September 26, our billings are $201.1 million compared to the same time last year was $209.5. As of today, the billing is actually at $204 million. So our average monthly billing is now at actually $17 million as of today compared to $17.4 million from last year. If you look on, I know it's kind of small, but if you look on the graph to the left of the data, it really tells a story of our journey this year with our billing. Beginning in October when we went live with the EHR, we did expect some decline in billings as we ramp up the EHR and get acclimated with it. So we did experience a decline in November and December. We did start to come back up in January and even February, and it's the solid line that represents the activities in FY23 in the current year. And then in March, when we lost the network, that really made a huge impact on our ability to bill. And so we did experience severe declines in March and April. In May, June, July, we started to pick back up again as we revamped, started getting access to the data and then the systems and all the resources that we needed to bill again. We were communicating with the insurance companies and the payers about our situation. And then I'm very happy to report in August, we had a stellar month of collections, and that's really all thanks to our revenue cycle team at the hospital. They are really just did an extraordinary job in August coming together. I mean, all together from registration to medical records, our coders, the billers, our revenue integrity unit, and collections. We billed $31.1 million in August alone. In September, we're tracking at about $28 million. These are exceptional numbers despite all of the hardships that we've had to come through. But the team has really come together. They're now led by a revenue cycle director, and she really coordinates and keeps track of all the efforts of everybody. So, and we've also hired 2 new billers and 1 Medicare biller. So our Medicare billing has really gone up. And we also have another coder. On the bottom half, I'm going to talk about the collections, which is the, after we bill, of course, the next step is to collect on the money. Because we've had an improved billing output in the last couple of months, we've really seen the direct impact actually on our Medicare collections. So right now, Medicare pays every day. Every day we get a collection. If we bill, we will get Medicare money immediately. Their turnaround time is 10 days. So our Medicare collections have really immediately improved. Medicaid is also coming in a lot faster. To help us get through those really dark times this year, we actually had some Medicaid advances from DOA just to help us through with those times when we weren't getting any collection. And so now our Medicaid collections have ramped back up, and we are paying back the advances that we made. Our third-party payers have also gotten better, but we do expect to see some more improvement maybe around November and December as a result of these last 2 months of better billing. But we still have some issues with particular payer that we work extra hard to try to collect. Our average monthly collections are now 9 million a month compared to 9.7 the same time last year. So we are making some improvements despite some of the very difficult times we've had this year. Next slide, please. And an update on our receivables and payables. Our net receivables as of August 31 is 62 million. Our Medicare and Medicaid are pretty much current. They're about within the last 12 months of billing is still in there. The third-party payers are pretty much current as well. We do have one payer we have some problems with that's taking up a bulk of that 17.8 million for the third party. And our self-pay is netted down to 5.7. These are not the gross receivables. Whenever we bill, it's the gross charges. But say, for example, when we bill Medicare, it will be the gross, but we will only get reimbursed for inpatient services on the per diem rate. So on our financial statements, we do net them out based on what we expect to collect. Our accounts payable as of 9/26 is 26.8 million. Our supplies are at 13.3 million. These are for our supplies, medical supplies and pharmaceuticals that we owe to vendors is at $13.3 million. It has really been very difficult to keep up with payers, paying the vendors just because we're so far behind. Even if we make an improvement in collections like we did the prior month and we're able to make some payments to the vendors, it's with this tremendous amount of payables, it's almost impossible to ever get caught up because as soon as we pay them, there are new invoices that are coming in. For utilities, it's at 2.2 million. That includes power and water. And our contractors and others is at 4.7. We still also owe for travel nurses. We are still utilizing travel nurses ever since the pandemic, but of course at a much lower rate than the pandemic rate we were paying before.
Thank you, Yuka. I just want to make a bigger deep dive for you in the supplies part of it. It does not go without notice that when we have over 60 vendors on credit hold with our critical meds, our laboratory supplies, our respiratory supplies, all of that, it definitely plays a major part in quality patient care. I am humbled and definitely overwhelmed by that, truthfully, as a leader.
I'm sorry, can you repeat that?
Yes, ma'am. What part? I'm sorry. If I can say...
What is it that you're grateful about?
I'm not grateful at all, ma'am. I am deeply overwhelmed by the amount of 60 vendors on credit hold, which includes our critical meds, our critical supplies, including laboratory, respiratory. This puts a definite damper on our staff, on our services, and on our patients.
Next slide, please.
Good afternoon, Speaker Terlaje. My name is William Candle. I'm the Associate Administrator of Operations. And good afternoon, Senators. Recently completed projects in this calendar year. Earlier this year, we completed the build-out of the telemedicine program expansion by rounding out we have 5 total rounders that we use. These are systems that are mobile. They go around and they allow the telemedicine technicians in working with the physicians off island to also care for the patients in critical areas. We've been completing rooftop repairs. We've completed this year in April, May, and July the A, B, D, and E wings rooftops. These are the upper rooftop portions of the hospital. We still have a lower rooftop section of the hospital to do. This is the C wing that is still not completed. That would be the final big section of GMH that would need to be done. That is over OR, L&D, OB ward, nursery. The main electrical distribution panel and sub-panels, we've been engaged, we've been collaborating with GPA. GPA has been completing quarterly preventive maintenance. So they've completed their passes in January, March, and July so far this year. We've been completing medical equipment packages, procurements for our alternate care site. As a part of the FEMA, this is a COVID, was a part of our COVID response and recovery medical equipment package, and also B-Wing HVAC system isolation. So we've been engaged in doing the reimbursements, the drawdowns, as we've completed those projects. We've been replacing air handling units. GMH air handling units, we've completed, or in the process of completing 25 out of 64 installations to date. And we've been making repairs to our GMH chillers. We've successfully repaired chiller number 1 through a combination of chemical and toothbrush cleaning as well as repairs using not only our staff, our facilities maintenance staff, which I am very proud of, but also our contractors that we've outsourced for. We have 2 contractors that help us maintain those chillers. We had to replace the VFD modules for chiller number 1. That happened in September, and the cleaning was completed in the middle of September. For chiller number 2, the repairs and toothbrush cleaning and chemical cleaning happened in the latter part of September. The VFD went in late June, but we found out that we had more significant issues with chiller number 2, and we still have ongoing repairs this week and next week relative to fixing a leak in the Freon system. Carrier is having to replace a valve on that chiller, and so we hope to operationalize that chiller fully in the coming week or 2.
We are, if I may interject, the chiller number 1 is fully functional, operational, and doing its job. So it is, now the hospital is a lot cooler. The units are a lot more comfortable and cooler. In fact, some of the employees are complaining that they're freezing, they're cold, but don't complain. It's a lot cooler.
The manufacturer's set point chill water temperature leaving these chillers for a new chiller is 44 degrees. Chiller number 1, after doing the cleaning and repairs, is achieving a 44-degree temperature Fahrenheit. So right now, it's fully operational. These are 11-year-old chillers. The useful life, according to the book, is 15 years. Given that Guam is a very corrosive environment, I'd say we're about at the useful life right now. So as we repair and maintain these 2 chillers, this really is our window of opportunity in the next year or 2 to replace them. So that's why we're heavily focused on getting those chillers replaced as soon as possible. Next slide. Additional HVAC system upgrades. Again, we're going after the replacement of the rest of that balance of air handling units. The reason why there are warm pockets in the hospital is not because of the chiller. It's because we need to replace the air handling units. Like I said, we've only replaced we're approaching 25 out of 64. So the rest of those air handling units is very critical to sustaining GMHA's operations. And so we're focused, we've done designs, we have designs in hand for the ED, ICU, OR, HVAC upgrades, and now we're trying to go after those projects.
Mr. Kando, can you please clarify for all of us, when you say air handling units, do you mean portable air conditioners that you're putting in?
No,
so
ma'am.
this is part of the HVAC system?
This is the AHUs these are fairly large air handling units.
All right.
That are a very important component of the HVAC system.
Okay, continue, please.
So, but you're right, we have been, as a contingency in the last few months, as a contingency because of our environment, we have been putting in portables and split units just as a backup, because if we ever have, anywhere along the way, if we have an issue with the chillers, we need that backup plan. And so we have put in, we have a total of 88 split units, not all of them recently installed, some of them very recently. And then we have 36 portable ACs that very recently we've been deploying and installing, just to keep those warm pockets, those areas where they need a new AHU. We're installing them in those areas. So that's the additional HVAC system upgrades. We have, just this past month, we were able to proceed with the liquid oxygen tank enclosure project. Two very large liquid oxygen tanks needed to be replaced, so this is a partnership, contractual partnership with Island Equipment to expand the concrete enclosure, and we're going to be putting in a 1,500-gallon tank, and then a much larger 3,000-gallon tank, so that we have a better redundancy during normal and emergency operations. We're replacing our hospital medical vacuum quadruplex system. This is a 4-pump system, so we've been having, again, this is another system that's been coming down towards the end of its useful life. So we recently brought in one new pump. We're bringing in 2 new pumps, but one just recently installed, just to keep us going, just to make sure that we don't lose the hospital-wide medical vacuum before we get a brand new quadruplex system. That takes time to manufacture, so we're just replacing a few pumps for now. We're proceeding, we're very close to fully executing a formal contract to replace our angio suite and our hemodynamic unit for the radiology department. That procurement record is now with the AG's office, and so we're working with the AG's office before they approve that package to legality and form, and then it would go to the governor's office. Other FF&E packages that Dr. Prince was talking about earlier on slide number 7, again, replacement of the OR towers, anesthesia machines, scopes, various other medical equipment that we're going to be looking at to replace, such as one of our fluoroscopy systems. We are very focused on the maternal and child health area. We are now engaged in an A&E firm. We're working with an A&E firm to do the design, the assessment and design concept phase for the conversion of the nursery into a NICU. The whole unit would become a NICU, which would then be able to do both NICU and intermediate care for the infants in that unit. We're looking at all 3 units, though. We're looking at L&D, we're looking at OB Ward, the full spatial footprint to see how we can maximize all 3 of those areas, because some of those units are very tight space. So we've described that. We've had that kickoff meeting with our A&E firm, and so that's what we're engaged in. Typhoon Mawa recovery phase has been very busy for us. We have a damage inventory around $14 million, so we're meeting with FEMA every week. So we're very close to, I believe, an approval of that damage inventory. I don't know what the final monetary tally will be, but we're also working very closely with our insurance company to make sure that we get reimbursed because we're covered, we're fully insured. Next slide. And then for the electronic health record, our update for today, we have continued support from the governor's office, and also that being the Office of Technology as well. The governor has allowed us to work closely with OTEC for technical assistance, to help us bring in firewalls and switches and server support when we did have the shutdown and the restoration. They were very helpful. Without them, we would have had a big challenge in doing that restoration, so we're very thankful to the governor and the Office of Technology, the Chief Frank Lujan. We brought in an assistant information and communications technology administrator very recently in early August. And so we have that assistant IT administrator now working, leading a EHR, electronic health record optimization project, because we need to be able to optimize this EHR that we have, that we've been struggling with. We're gonna try to work very closely between information technology and the team that is called informatics team, and of course the end users, nursing, physicians, so that we can try to optimize this EHR. It is our system. We have to, as long as we have this existing system, we need to make the most of it. We're working with our EHR vendors to address systems interface and support issues. We have additional planned IT network and systems infrastructure upgrades that we're already launching. For example, we're in the procurement process for replacing our end computing devices. We are going to be doing an RFP, probably an RFP for the purchase of a domain management system, which we didn't have, and that was identified as a weakness when we did the after-action report, an improvement plan for the shutdown and restoration. And then we're looking to transition from our current RCM software application to an RCM cloud application, and other improvements that are not, not as big as these, all to support the electronic health record. Other projects that are in the pipeline, we still have a small section of the Z-Wing that we need to demolish, and then retrofit, restore the first floor. So it's only the second floor that would be demolished. We are making repairs to our boilers and water heaters, and we are planning to replace our boilers as well, especially boiler number 2, which is the older of the two. We're looking to relocate and replace the main electrical distribution panel and sub-panels, as Lillian had mentioned earlier, as a part of that $15 million. We're planning to remove and replace our 1.6 megawatt emergency generator. This one had been previously funded through a DOI fund, but then we shifted a small amount of those funds to our HVAC system. Because when we went out to bid, the funding that we had for that 1.6 meg generator was far below what we needed. So the bid came well above the budgeted amount that we had. So we think that, though, that we can circle back on this 1.6 meg generator. This is in working with FEMA. It is identified as one of our hazard mitigation projects that may come out of this Typhoon Mawar recovery. And then we need to replace our CCTV surveillance and also our access control systems, as these are slowly starting to fail. It's becoming very difficult to maintain them, and because pretty soon the support for those parts is probably going to go away.
Next slide. In regards to the medical staff, we actually have approximately 156 total active medical staff, which includes telemedicine, of which about 18 of our credential providers are in telemedicine. It is a stable number of providers. It's enough, but it's not sustainable. In regards to our telemedicine services, what do we do? What is our vision? I'll tell you what my vision is as the acting medical director, is to have telemedicine be an augment, right? It's not like having somebody with you, which is ultimately the best thing, having the doctor right in front of you. But with the augment, right now we have internal medicine, pediatrics, which includes PICU, NICU, and in radiology as well. We have some active recruitment going on, and it's not limited to interventional cardiology, OBGYN, pediatricians, vascular surgery, orthopedics, and neonatology. I'll be honest with you, the challenges is bringing doctors to the island is pay. It is tough to compete for hires when the focus is only on pay. But it does not give me any excuse not to work on different avenues, such as what else is valuable, such as maybe cost of living allowance adjustments, possibly working with the community with housing stipends and or arrangements. Of note, with locums that comes from the locums staffing agency, there are many providers that are demanding $250 a month for a housing and an auto stipend. We do not do this. Then there's also the other challenges for the providers is having the medical equipment and having a functioning electronic health record. These are the challenges that are facing us with the medical staff. Lillian?
Mm-hmm. Next slide, please. Just to kind of give you an overview as far as our nursing services division and how we're always talking about nursing shortage, these two graphs just kind of show you where we are, what the numbers are with regards to nurses, LPNs, and the travel nurses that we currently have at our facility. And really the goal is that we will try and minimize our reliance, our dependency on the travel nurses because it is quite costly. And kudos to our nursing administrator and the deputy. They were very successful to then convert some of these very costly travel nurses to then become locally employed through an employment contract. So we can continue that track, that strategy. I think we can pretty much reach a more manageable number of travel nurses because the reality is, with the nursing shortage nationwide, the travel nurse industry is what's augmenting and supplying the hospitals. And so we may need to continue relying on some of these travel nurses, although we'd like for the University of Guam to ramp up their graduate numbers, from their program, and that can help to meet the demand of our island healthcare system. So that just kind of shows you, and on that other side, on the right side, as far as the nurses that we hire, yes, in 2023, we hired 36 nurses, but then we lost 56 nurses. So again, we're not able to retain these nurses. And the next slide kind of shows you on a monthly basis just how many nurses that we recruit and how many we lose. You can go to the next slide, and we'll touch more on the nursing recruitment and retention challenges, the reasons why nurses leave GMH and also the island. Ultimately, is they go for higher salaries. That's just what they're looking for, especially the young ones. I did it myself. I went off island because I could earn more money, but then I came back because I fell in love with the local guys. So I'm hoping that these young nurses will come back. Anyway. The other reason is that they desire to live off island for adventure. And, burnout, it's a very common issue across the nation for nurses, and not only nurses, but also doctors and other health professionals. The working conditions, the working environment, that's another reason why these nurses leave. And then also the attractive federal and private health facility jobs here on Guam. So we're competing with other health facilities that pay them higher. And some of the recruitment and retention strategies that we have on the docket is that we'd like to adjust the salaries of hospital nurses for a more competitive wage, and that's going to need some funding support. We have transitioned travel nurses, as I mentioned earlier, to local contract employment, and we've also launched a structured advanced training for specialty nurses in the ICU, in the pediatric, NICU, PICU, and trauma nursing practice. We'd like to also, and we are going to begin launching the nursing leadership coaching and mentoring program. And then also we've started, we're doing an RFP for recruitment services at the national and international level. The Philippines has a lot of nurses that graduate, and so we're looking to see how we can recruit from that country. But of course, we're going to need to deal with the immigration requirements. And in terms, again, of the nursing shortage, right now, if we want to open every single bed in the acute care and the SNF, we need 79 full-time nurses. And so that's the goal, is that, we'd like to achieve, is to get 79 more nurses. I know it's a big goal, but, why not? Let's just try and keep working towards that. And I like to end on a positive note. We have successes and we have win-wins. And that recently, our medical laboratory, our radiology, the American College of Radiology accreditation for our CT program, the laboratory, the College of American Pathologists, this is the CAP accreditation for our lab, and they went through that survey about 2 weeks ago, and they accredited our laboratory. The CLIA, that's the Clinical Laboratory Improvement Amendments for our arterial blood gas program that is managed and administered by the Respiratory Therapy Department. We are accredited by the CMS for that service. The CMS Center for Medicare and Medicaid, we are certified, so we continue to receive Medicare and Medicaid fundings. And then also our SNF, skilled nursing facility, which houses the skilled nursing unit, we are certified again by CMS, so we continue to receive Medicare funding, Medicaid. So next slide. Senators, we are open to your questions. We're here to answer them, no matter how difficult they are.
Thank you very much.
Thank you.
I think we also have some GMH employees who wanted to testify. You're welcome to come up now and testify.
Hafidei Zen Buenas tardes, Speaker Terlaje and Senators. My name is Isabel Flores. I am a certified critical care nurse working in the adult ICU at GMH. I did not attend nursing school here. I went to nursing school in California, where I trained at a variety of hospitals in San Diego, to include Rady Children's Hospital. I started my nursing career at a magnet-designated hospital, and a magnet-designated hospital, for those of you that don't know, is a medical facility considered to be the gold standard for nursing practice and innovation. As we are all aware, GMH is not a magnet-designated hospital, and it is very far from it. I'm here today to share that despite what the administration has previously said, the state of the hospital is far from good, and we did not handle the typhoon well. During the storm, there was widespread flooding, stairwells and elevators turned into waterfalls, ceilings and walls caved in, loose shutters banged on the windows for hours. There were multiple electrical fires in the mother and baby unit. And now it smells so musty throughout the facility. I was at GMH for 72 hours straight during the storm, sleeping on cots in the hallways with my fellow colleagues. And I know every single one of them would agree with me when I say that that building will not withstand another typhoon. It's common knowledge that water and electricity do not mix well. And that was made obvious when we had to evacuate the OB ward because there was so much smoke coming from the outlets due to electrical fires. There was also a very big electrical fire in the cafeteria. During the storm, an unfamiliar overhead page was announced. Any available staff report to the generator room immediately. The lift gate in the generator room almost blew in. The heroes of the night, and I want to emphasize that they were true heroes, were the facilities maintenance men who literally held the building together with their own hands and 2x4s. Do you know how disastrous it would have been if the generator room flooded and blew in? We do not have enough staff to manually bag every ventilated patient for days. And our most recent event that happened was a snake was found in the ceiling of our infection control office. Snakes do not belong in hospitals. That's just unacceptable. And what I'm really struggling to understand is that during the COVID-19 pandemic, GMH received millions of dollars in federal funding. Yet why is it that we are worse off than we ever were before? And those are not even my words. Those are the words of a colleague who has been at GMH for over 30 years. So she has a little more perspective than I do. We regularly lack essential materials like linens and pillows, diabetic tube feeding formula, underpads for patients to poo and pee on, inner tracheostomy cannulas, wipes to clean patients, pre-filled epinephrine syringes for medical emergencies, and there's so many other things that I can add to this list. Where did all this COVID money go? As healthcare providers, we are being asked to provide care without being given the tools needed to practice that care safely and, frankly, up to the normal standards of care today. The policies that were made for GMH are extremely outdated. I'm here to testify, to plead with you that we rethink how we appoint the leadership of this agency. Our hospital administrators and board of trustees cannot be politically appointed positions, because a politically appointed person's loyalty aligns with their political party. It does not lie with patient care and safety and the overall well-being of the hospital. I know this is the way it has been for years, but where has that gotten us? A dilapidated building rampant with mold, with snakes living in the ceilings. The superintendent of the Guam Department of Education is hired by the Guam Education Board. Guam Power Authority has a public-private partnership with Therese to maintain the power plants. The government of Guam has not been able to maintain the public pools. What more a hospital agency? GMH needs systemic change because the existing systems are not working. We need administrators who are hired based on their qualifications and who are credentialed to run a hospital organization. Administrators whose priorities are patient safety and most especially financial literacy, catering to an indigent population, because that is the population that we serve. There was talk of getting the hospital out of government procurement, and that would be so great. We need supplies at a much faster pace than government procurement allows for, except someone put a halt on that. There are only a few reasons I can think of why someone would not want GMH to do their own procurement. And that is, one, they just simply do not understand how important doing their own procurement is. And two, they probably know someone who has a government bid that supplies the hospital and they don't want to cut ties with that person. We didn't have wipes for months. As an alternative, we were told to use paper towels to clean and bathe our patients. To our embarrassment, patients' families witnessed this and have donated wipes because of the pitiful situation the hospital is in. It's sad and it's embarrassing and it's disgraceful that you have allowed this to be the standard of care for our patients, for our people of Guam. We often don't have pillows for our patients or clean linens and gowns. Imagine yourself in that bed, or your mother or your child, laying in their soiled personal clothes, soiled sheets, with a rolled up blanket under their head for a pillow. The second chiller went down after the typhoon and it was hot in the hospital. The solution to this is standing fans and portable AC units in various parts of the hospital, and thankfully things are much cooler. But I really wonder how much all these portable air conditioners cost. How much was spent on the fans? Where will they store all of these? Because after COVID settled, they stored all the portable vents in the viewing room, and the viewing room was unavailable for families for months. And only when we had pushed for the viewing room to be reopened after many, many frustrating experiences with dying patients and their limited family members at the bedside because of restricted visitation, did they finally work on reopening the viewing room. Several months ago, there was a big push on waxing the floors. And it's comical to me that of all the things that need fixing in the hospital, waxing the floors was such a priority. And I wonder how much that project cost. Our copy machine was down for weeks in our unit because we haven't paid the Xerox vendor. So no faxing important documents, had to borrow other fax machines from different units. Maybe those waxing funds should have been used to pay Xerox. There's been a recent hold on new employee access to our electronic health record due to the $234,000 we owe to CareView and MedSphere. So incoming nurses have been told to share their access with another nurse, which may compromise the license of that nurse sharing their access. All this to say that the disconnect between the people making the decisions and those that have to work with those decisions on a daily basis is so unreal. Speaking of disconnected decisions, the most prime example I can think of was the recent shutdown of our entire hospital network, including the phone system. A memo went out for the hospital-wide system maintenance for an estimated 48 hours, as stated in the memo sent to our employees. This official communication to the employees was fraudulent. The shutdown was not for system maintenance, but a suspected breach in our network system. The decision to shut down was made by a select few administrators and the legal team, with no communication to the medical staff for over a week to share the actual truth about the situation. And the saddest part is that the after-action report indicated that there was no breach of protected health information, meaning the shutdown was completely unwarranted. The 48-hour network shutdown turned into 5+ weeks in which we were forced to go into complete manual mode. Staff were utilizing their personal cell phones to communicate with different departments in the hospital, to communicate with families. All documentation was handwritten, including urgent lab and radiology reports that had to be physically walked over to each respected department. The situation left us without the crucial established safety checks, and patient safety during this time was solely dependent on the diligence of the nurse and the ancillary staff. There was so much room for human error. Billing was also greatly affected due to the inability to electronically capture hospital charges. The scope of financial and potential patient harm due to the poor decision-making of these select administrators and the legal team is still not fully known, and honestly won't ever be known because there's no way to track it. One of my biggest reasons for being here today is that this past year I witnessed a beautiful child die. And I will never, ever forget that experience. And what happened after this death? Nothing. No debrief on the situation, no evaluation of our pediatric ward, no grants written to improve our pediatric unit, no mandatory training to sharpen our nurses' knowledge and skills. As a matter of fact, we've gotten pushback as to why our nurses need more training from our own administration. GMH is the only public facility in over 1,000 miles that can treat children in an acute care setting. GMH is our children's hospital. If that doesn't make each and every one of you want to jump out of your seats and build the hospital yourself, then you really shouldn't be sitting in those seats. God forbid that a child that you know and love has to be hospitalized, and then you will really see the conditions and the limited resources that GMH is working with. I can tell you all of the things that we go through on a daily basis, but frankly, I don't think any of you really care, because if you did, there would be some change. If you're not sitting in those seats to actively advance the lives of the people here, to make Guam a better place, then you shouldn't be in those chairs. Eagles Field was shut down. Okay, what's next? We haven't heard any word on that. We need a new public hospital. As senators, it is literally your obligation to figure out a plan for a new hospital. And for those of you that have been in office for 5, 10 years or more, who have failed to prioritize progress and improvement in our healthcare system, your complacency has really cost many lives, and that blood is on your hands. And I'm not sitting here complaining for my own benefit. I'm here because I'm the one taking care of the people in those beds, and I want better for them. But I'm wasting my breath sitting here and asking what the plan is, because I know none of you actually have a plan. Because if there were a plan, there would be some action. Not just words, because words mean nothing without action that follows. I'm here to tell you what we need, and that is first and foremost a new hospital building, if not for anyone but for our children. And secondly, a new hospital building that is led by qualified administrators who are hired based on their ability and training to run a hospital organization. GMH must be depoliticized, and anyone who is against this idea is against the health and well-being of our people, and they are against improving our island. Thank you.
Thank you very much, Ms. Flores.
Thank you, Speaker Terlaje and senators and the board. My name is William Eric Lee. I have been a nurse for 23 years almost. I currently am working in the ICU part-time. I actually am teaching at GCC as well. Isabel's testimony resonates. Like, I can feel everything that she talked about. Weeks after my war, you know, back in 2020, we walked in wearing masks to protect against COVID. Now we're wearing masks to protect against mold, spores. Those are the types of things that we're facing right now after my war, and it kind of worries me, because if I'm worrying about getting sick, what's happening to those patients that's in those beds? Those patients that's on the ventilator, those patients that have pulmonary problems, those are the patients that are immunocompromised. Those are the patients that will die on you very quickly. We cannot support our organization the way it's going now. There has to be change. Our patients' lives are at stake. The health of our staff is at stake. The health of the visitors are at stake. All of these things are important. Our mission statement talks about quality. GMH, and I've worked at many hospitals, at least 50. GMH is at the lowest level of any. Isabel talked about magnet status. I know that we would never be magnet status because we're not at that level. Magnet status is the highest quality in nursing care and quality care that's provided to all patients. Unfortunately, ours is substandard. Our care is substandard. I don't care what unit we're talking about, it is substandard. When you're having to borrow wipes, someone brings wipes to you because they're donating those to you to help clean your patients. We used, and I agree, we used tissue. Listen, tissue paper by the sink to wipe our patients. And we were told that we do not have the money to use for wipes. Simple things. What do you normally do when you go take care of your baby? You go buy wipes. Here we are telling family members we don't have wipes, but we're going to wet these tissues and wipe our patients with them. That's uncalled for. It's embarrassing. It's embarrassing as a teacher because I have to tell my students, don't do this. This is not the way it's done. It's not a standard of practice. That is what we're having to face. We've gotten better. Our temperature, yes, has gotten a little bit cooler, but I can assure you I still have to wear some sort of fan around my neck whenever I go to work. This is uncalled for. You can't do that. You cannot take care of patients when you're sweating. You cannot take care of patients when you're hot. You're not doing your best productive work. Our air conditioning system is horrible. Today I had students. 4th floor was not any cooler. It still was the same temp as it was last week, which was also hot. So I'm saying, can we please have this legislature help us to move GMH forward, because we're not moving forward. We're still standing still. We're still years behind. We're not even nowhere near the baseline that most other hospital organizations in the states are at. We're far below that. One of my critical things that I do want to ask today, and yes, I do have administration in front of me, I want to understand how can CMS walk into our hospital, see the structure the way it is right now. There is ceiling tiles that's falling. There is paint on the wall that still has water behind the bubble. There is plants growing out of those water bubbles. What kind of mold is underneath the paint that we painted over? What kind of mold is there? Black mold? What kind of spores? Everyone knows what Legionnaire's disease is. Air conditioning systems. Air conditioning systems bringing spores in that's causing problems for our patients, our critical patients that are immunocompromised. Not to mention the fact that mostly, elderly populations, that includes some of our workers. Some of our workers are elderly, and they're still working. That puts them at risk of getting sickness, illness, and even death. Not to mention the fact that COVID is out there, and along with the flu. I'm no longer scared of COVID. I'm now scared of mold, spores, things like that. That's what I'm more worried about now. I thank you. Suzuki Masi.
Thank you very much. Can you repeat your name one more time?
It's William Eric Lee.
Thank you. Anyone else? Anyone else to testify? All right. Okay, thank you all for your testimony. As I said in the beginning, I don't think we're going to be able in this one hearing to address everything or even talk about it. Some of us, let's try to hammer out some solutions to some of the issues. And I don't think we're going to resolve the new hospital today, but I totally agree with you that must be resolved. We have to have that plan. Anyways, I'm not going to speak further on that just because of time, but I agree with you. I think everyone agrees it's a matter of who's running that plan and if they're going to allow us to cooperate or not. Eaglesfield was shut down because they would not share the plans. We are proposing other sites and trying to move forward on those. All right, so I'm just trying to think of a way to address these things that does not minimize the true concerns. We're going to talk about money, which may not, it doesn't address a baby that died, and, you know, so I'm very sorry about that. We're just going to try to do our best and talk about these things, so please forgive us if it doesn't address everything today. I'm going to start off with the money, I guess, because this is the issue. Staff is being told that it's money that's the issue, right? It's money why they aren't able to get wipes. It's money, but this has been controverted by GMH and or denied, right? Until just very recently, when we were told in the budget hearing that we are this far behind on billings. That was July, we had the hearing. That's when we were told that we were so far behind that, in your words, it's overwhelming. So far behind in billing. A lot of it, yes, because of the shutdown of the information systems, the conversion, and now we're on hold with this same vendor for non-payment. So when one of your, in your presentation, you said one of your solutions is that you hired somebody, where did I put that? You hired a new person, an assistant INCT administrator to lead the EHR optimization project. It's, has this person experienced in optimizing the EHR for hospitals?
Perhaps not specifically in EHR, but certified in cybersecurity and also in project management, so.
All right, but I think for me, that's part of the issue. It's like we get people who are certified in things, but cybersecurity is not our issue. EHR transition and how to get that into the billing system and the EHR system to work together is the issue, right? And it wasn't complete. And you're now proposing another upgrade. It says to address, you're working with the EHR vendors to address systems interface and support issues, but they're on hold for non-payment. I don't know. Okay, let me, I have a whole list of item by item what I want to talk to, but let's just talk about the big picture. So when GMH comes, makes a budget request, sticks to the cap that the governor gives, again, the governor requested for the FY24 budget status quo for the FY23. And we had to go in, and I asked the chair at the time to give more money to GMH. We did. But it's, of course, it's not everything you need, and I don't even think we've seen all those lists, but still, it's kind of like there's this big disconnect between what GMH needs versus what GMH will admit it needs, what GMH will ask the governor for, what GMH will ask the senators for, what GMH will say, please give us the money that's been appropriated to us, because we saw the reports during the budget that you didn't even receive all the money that was appropriated. And then you said again today, 10 million. I mean, all of this stuff. And now it's years later. So now the problems are so huge that it's mind-boggling. But the collections, right before the last election, I mean, you were working with the Attorney General's office. Collections, whenever I asked you, they were fine. That you were working with the Attorney General's office, and they were taking care of any problems that you had in collections. And now we have a collections problem that seems to be 50% of the bills. And I don't know. And so we've heard, of course, in the interim of some vendor that was hired to take care of collections. That didn't make sense to me at the time because that was never your issue before. And now, yeah, everything has come together to, like, changing your systems in the middle of the thing, changing the EHR system, your collection systems, and shutting down the information system, the electronic system altogether. Yeah, all of it. Of course, COVID and a typhoon, but still. It was 5 years ago. No, it was, it was in 2020 when the Army Corps said straight out the changes that it thought GMH needed to make. That was 2020. And one of the number ones that they specifically said, roof replacement, exterior building repairs, HVAC repairs, life safety repairs, and fire sprinkler repairs. So, and then during COVID, we heard of the HVAC system upgrades that you were doing to keep the air clean. But yeah, I guess what's frustrating, to say the least, is that in the most recent board meeting, the board members are being told, oh, okay, we're going to get a new HVAC system and it's going to take us 2 years. Like, we're just beginning that process. And I see your list of parts of the HVAC system that you've completed or are completing, and now you've cleaned and repaired, like the first cooler repair and chemical tube brush cleaning of chiller 1. So now you're saying that one's operable. But I guess what's not making sense to me is if we were told we need to replace those systems in 2020, and then the board's being told in 2023, by the way, we need to replace those systems and it's going to take us 2 years, that makes no sense. That was the Army Corps' plan of how we're going to get through 5 years while we're building a new hospital. And we don't have any 3 more years before we can build that new hospital. We have to build it now. No one predicted this current hospital could last more than 5 years. So, all right, let's just start with the mold. Oh, no, I'm sorry. Forgive me, I'm a little bit emotional too after hearing all the testimony, but let's follow up with some things. So at the budget session, we asked you, how are you going to resolve this vendor payable issue? 30 million at that time, 26 million today. You said you were going to get 2.1 million from the governor to pay for the Department of Corrections medical services. You were going to get another 6 million transferred to GMH. Did this happen? Yes?
Yes, it did.
All right, and that's separate from the DOA advancing the Medicaid that you had to pay back?
It's separate. We
Okay.
use that 6 million to pay the payables such as MD Wholesale that provides us, the medical supplies and medication, GPA that for our utilities, another pharmaceutical vendor. So that 6 million was just absorbed from, by just a few number of vendors.
All right. And so he says he's overwhelmed, but Yuka, do you have a plan for these vendors?
The best we can do right now with the limited funds that we do have is we try to at least make partial payment. So if we owe a vendor $1 million, we will try to squeeze out at least 50,000 for each of the vendors that we owe. So instead of paying a large sum of money to one vendor, we're trying to divvy it up so at least there's movement on the accounts. And most of the time that's okay with the vendor, but I don't think it will last very long. They're going to eventually ask for, we want to get the whole amount right now. Or
Well,
we're gonna
didn't
stop.
you testify that there's 60 vendors on hold already?
Well, yes, but when we do make a partial payment, they usually will lift the credit
Okay,
hold.
so what's the plan to pay them off?
We make the smallest payment that we can and try to pay as many vendors as we can instead of making a big payment. But we really do need a large cash infusion in order to make a dent in these payables. So even if we have an increase in collections and available cash, it's immediately absorbed. We can spend it in the blink of an eye just to pay the vendors down, and then another bunch of invoices come in because these supplies and pharmaceuticals are very expensive. We're paying a lot more than we used to, so it's been overwhelming. The thing that saved us in the past year or two, we had extra money from COVID. We had a lot of money coming in from the federal government. That has stopped. We have not had any of that come in this year at all. In 2020, 21, 22, the federal government was throwing money at us. So we were able to meet the increased expenses. We even had to pay all this differential pay to the staff to make sure they don't leave work and they stay and help take care of patients. That costs a lot of money, and then the costs of everything just went up. And they're still high. They're still expensive.
The current request for your budget, let's say the vendors were taken care of and you were up to date. Does your budget currently going to allow you to operate without that deficit? Or are you going to operate and result in another deficit at the end of the year?
Well, I hope we don't. I think if we just have something to help us get caught up with the vendors, we can stay on track if we keep on our track with the way that we've been billing so far and follow up with the collections. We've been a lot more aggressive with the payers. The insurance companies, I will admit, one is really giving us a hard time. They don't pay us. And that's very difficult when they don't pay us. The other payers are fine. They pay us every week. Medicare pays us every day.
You hired 2 attorneys, used to be none in the last year. So
Yes.
what about that? Oh, I'm assuming you hired attorneys because you're having problems, but it doesn't seem to be resulting in anything different. It's worse after you hired attorneys than when you didn't hire any. Are they helping you with that problem payer?
They are. If I may just go back to how our collections are, and if I may reiterate, Medicare pays us on a per diem rate. So if my hospital bill is $10,000 per day, Medicare will only take GMH $1,500.
I know, sorry,
So
Lillian.
that's the problem, is although we can be very aggressive with our collection, the reimbursement is not 100%.
Okay, I'm sorry, but that's why I asked. If we operate it the way you plan, are you going to result in a deficit? And are you telling me we will always result in deficit, or that you've made a plan to that accommodates the lower reimbursement from Medicare?
We plan to hire, hopefully we have an RFP out by the end of the year to get a consultant so that we can work on the rebasing for Medicare. That's the only way we're going to get our per diem rate up. That is the only way. Right now, we're capped at
Okay,
a
I know, and
discharge.
you've been saying that for years as well. So I'm asking, you should be working on that rebase, but what about your operation? Have you made a plan that you're going to operate without a deficit?
Yes,
Yes?
yes.
And that's based on billings?
Billings and our projected revenues. However, what's really pulling us back is our payables right now.
Right, so I know,
That's
okay,
really
so
pulling
that's
us
why I
back.
said, if the payables were taken care of, I just want to know that we have a system in place that's supposed to come out or
Yes.
at least break even.
At least break even,
Right?
yes.
If it's managed correctly.
Yes, properly. Yes,
right.
absolutely, I agree. Yes, it's really the
And
payables.
that you're saying that is your system. Because I think that many in the community believe we do not have a system that can even break even, but we do.
We do.
We just fell behind.
We did fall very behind, and like I demonstrated in those slides, I mean, it's really been where we fell. We had expected something after the EHR. We knew just based on experience and from what we researched is that it's going to take a month or two just to get caught up, and we did. When the network shut down in March, that was very unexpected, and the consequences of that, especially on the billing side, was detrimental. We barely billed anything in April. Hardly anything went out. So we lost 1 month. The next month, we still couldn't get caught up because we didn't have any medical records and charges weren't dropping. So the staff worked really hard, but it took a few months to finally get caught up. So all those months that have been lost, I'm glad we're up to par now, but we still have months that we lost billings already, which is hurting us right now. Big time.
Yes. All right, and so I want you to be really honest with us. This EHR system, are you going to be able to merge it with your billings? Are you going to be able to continue with this vendor? And are you going to be able to make it work for you?
That's what our multidisciplinary team is working on. The IT and the informatics and some of the subject matter experts who are the nurse, the clinical staff. But this is what we have right now. This is the product, and we are trying to make the best use of it. But we recognize that actually this product was not built for an acute care hospital, is what we discovered. It's built for a behavioral health setting. Recognizing that, we are proceeding to do an RFP for an EHR record that is specific to an acute care hospital setting. And we actually inherited this product, MedSphere CareView, from the previous vendor that was affiliated with this company. That was the recommendation when they were sunsetting their product, the EHR that we had in our system. When they were sunsetting that, they recommended that we just migrate into this product that is affiliated with their company. So we did not go through an RFP process. We went through the novation process. And that's when, that's why we have this product with us. But we recognize it's not meeting our needs. And so therefore, we are proceeding to then do an RFP for another EHR product that does fit in an acute care hospital setting.
I don't know how to express this, but there's so many things that are being said today that I've been doing oversights for 3 years, and I'm hearing things today that I just want to say, what? Never heard that before. When you were transferring to this new EHR, you said, yes, it was recommended by the company. That's why I'm wondering, do we really have the did you procure the expertise that we needed to decide which EHR system we're going to go down? Because to hear now that now you want to procure an EHR system, this is something that has been in the works for years. It was delayed, and we kept saying that was going to be your silver bullet to make sure that everything's recorded, that we can get our billings done fast. That was it, but it took forever, and now you're telling me it wasn't done right, and now we have to do it all over again? You're not even talking now about emerging. Now you're talking about a whole new system?
Yes, Madam.
You want to procure a whole new system?
We need to, because the system that we have right now, as I said, it was recommended by the experts. We relied on the experts. And
yes, that's why I'm asking, what are we going to do going forward? Because I don't know what experts we're relying on, but we need experts in this, even right now, let alone in procuring a whole new system. I am just kind of surprised. That I wish, what I want to do, this is my style, is to go back and pull out all the hearings we've had and quote all of you back to what you've told me over the years as to why you're going with this one vendor, why you did not do it that way or this way, you're doing it this way because you believed at the time it was the greatest thing. And now you're telling me, oh no, it's like they did us wrong, or you're saying, oh, we just got so far behind, like it happened to you and it was not you who are controlling it. All right. Okay, so the vendors, the plan, there's no plan that GMH has right now to take care of these vendors. You need an infusion of cash from somewhere in order to pay. The money, we talked before about the appropriations that you've not received yet. We talked about the appropriations for other things. For example, the labor and delivery award. you talked about changes today to maternal care, but what about the labor and delivery ward? Is that not going to happen? So what about that money? Are you able to use that? Or have you asked the governor? What is your communications, I guess, with the administration or BBMR and the governor and DOA as to what parts of those appropriations you can have right now while you're in this crisis? Are there any? Because it looks to us like outstanding appropriations.
Well,
I think the audits show that. They show the labor and delivery money. They show, yeah,
so the
the 10
Senator,
million.
Speaker Terlaje, again, we're waiting for the completion of the audit to see if there's going to be a surplus that is going to make us realize $15 million for CIPs. One of them would be for the MCH areas. We're not waiting for that, although it should be coming out shortly. So we're already proceeding with the A&E design phase, the design concept, the assessment phase. So at least we've gotten that going, using operational funds to get it going. But we do need, of course, you know, whatever construction that we do is going to be very expensive.
It's going to be what?
Very, very expensive. So hopefully that 15 million will come to realization, but we're still waiting for the government-wide audit to come to completion.
Is this plan of yours that you're calling the maternal care renovation the same as renovating this labor and delivery ward that had been on the books for years?
No.
Or is it a
no.
completely different plan that is now being put on the table, right?
Of course, we're looking.
And you want to use that money, or you haven't planned? You're using your own money now. You've prioritized that over.
Well, we're working with the same designer, the same design team. We're looking first internally with our existing spatial footprint to start designing to renovate the existing footprint, because we know we can make improvements internally. The original L&D, the original Family Birth Center design was to also include new construction in our front courtyard. Right now, no, we're not planning to do that. We were planning for a new hospital. So why would we be planning for new construction?
The new hospital had nothing to do with the labor and delivery renovation. I don't understand that.
That's right. That came well before the idea of building a new hospital.
Yes,
But when the governor came into her administration, that was the vision, to build a new hospital.
And not do
because
the
we all
labor and
believe, we all thoroughly believe that a new hospital is needed.
of course. And we were trying to build it faster than we could renovate the labor and delivery, but that didn't happen either. But now you're telling me you're going to renovate the labor and delivery.
Starting with the nursery.
And that was just, the design has begun starting in August this year. That's what,
The design assessment and concept for the nursery, yes.
yeah, like you're just beginning to talk about that right now. Right? So we're going to pay again another design, because we paid for the design, remember? Money was appropriated for the design of that whole thing. All right. I guess that's why I'm saying, you know, that it's frustrating, because we focus on roof repair, elevator, the new EHR system, and the HVAC repairs, to name a few. But every year when we come in, you give us this story, this is going to get done, this is our plan for this. But now, those aren't even done. And we're in other projects that may be critical, but our other critical projects were not done. And
The roof repair has already been completed for some of the wings, so that has begun.
The majority of the roof has been
are you saying before the typhoon or after the typhoon?
before the typhoon.
Yeah, before the typhoon.
It was completed. That's not why the hospital flooded. The hospital flooded into our main lobby from the Z wing, which is scheduled for demolition, and because the drains were covered by solar panels. And so when the water had nowhere to go, it started seeping through seismic joints into the main lobby, down past the kitchen, the dietary, and we had to wipe it, we had to wash it out Even Dr. Prinz was helping us push it into the
Yeah,
courtyard.
but that's not all that we saw during the typhoon, right? I mean, there was water literally coming
That's right,
out
that's
of
right, because the roof
roofs.
upgrade is one aspect, but it's the roof and envelope that needed to be replaced. That's we
That's
haven't
correct.
done the envelope.
That's the first
So
thing the
now,
Army
as
Corps
a
said.
result of Typhoon Mawa, we have an opportunity in working with FEMA to also take care of the envelope, which is sealing our windows, putting in new typhoon shutters, even possible wall mitigations in our courtyards. All of that is in our damage inventory for Typhoon Mawa.
All right, and then so you testified today that the cooler is cooling the hospital and that you put in some air conditioners temporary, but I still have received letters even today regarding how hot it is. This is from doctors, this is from different people saying how hot it is, even in where the babies are being delivered, labor, and ER, and that the mold is still existing. What is the mold solution?
So we did sign a purchase order today for a industrial hygienist, one of the companies, a local company, to do a mold assessment and mold remediation project, which should be completed in the next, I believe, 2 to 3 weeks. They're going to be assessing for mold both GMH and the skilled nursing facility. And so that also is a part of the Typhoon Mawa recovery package. And so we'll see what the results of that hospital-wide and skilled nursing facility-wide mold assessment will reveal.
Why did it take so long to get that mold contract even put on the table? I mean,
We had to go through the procurement process. Actually, we were able to avoid we were able to avoid an RFP process. It was actually an RFQ process, request for quotation. We were able to get we're lucky that we got the local contractor that actually came in below 25,000. So and then we went through a process where we had to cure their quotations because they were missing, there was questions that we had to get answered so that we could know what their costs were. So we finally succeeded this week.
If I may, just one moment.
Dr. Lee?
So, yes, so my concern is this time space that we have. We're just now going to procure a mold expert. What happens to those families? And we're all connected here, y'all. You have families everywhere, so you know that you probably have a family member in the hospital. This mold can cause lots of illnesses. I wouldn't want my mother, just like Isabel was saying, I would not want my mother or father in the hospital knowing that I'm even scared to even breathe. When I know that when I'm walking into the hospital, that's when I start coughing and I feel sicker being in the hospital than I do on the outside. How are we going to correct this where there is a space and time when we should have worked on this weeks and weeks ago, right after my war? That should have been the first thing that we should have had administration do, is look at what is going to protect the patients and the workers and the families in our hospital. Thank you.
Thank you. Was that considered, like hiring somebody to protect against mold even before they assess the mold? Is that possible? Was that ever considered? Because I agree. I mean, this sounds like a DOE situation all over again where we were in emergency. We authorized all kinds of money for this emergency, $50 million for this, for mold, and it took months to even begin to assess for mold, let alone solve for mold. And all right, is there anything else on the table for mold?
I just think that we needed to do it. We also had to do it, in the framework of working with FEMA. So I mean, we couldn't just. I mean, we want reimbursement also for that. So we just had to go through the process, and so we'll see what the results reveal. I suggest we wait till we let the experts tell us what the results are before we make any judgments. We need to see what they sample for and what the results are.
All right. So this is the same issue that we had with DOE. They didn't want to cure the mold or prevent the teachers from inhaling the mold until they were sure that they were going to get FEMA reimbursement. And I just can't see why that's logical for your hospital when you've got patients and it doesn't matter whether we get FEMA reimbursement or not. And I agree you should do the process that will get us reimbursement, but I don't know, to wait this long and blame it on FEMA it just seems unreasonable for me, to me. I'm gonna, let's hear from my colleagues while I recollect my thoughts. Senator Brown.
Maybe, Speaker, you're a little more patient than I am. I have to scroll here because I'm so irritated. This is a cluster mess. Now, you know, I appreciate those of you on the staff coming forth to relay your realities there, but, you know, Ms. Flores, you probably have a more direct line to the administration than some of us up here do. There's nothing to justify the inability to get basic sanitation rights at the hospital. There is just nothing in my mind that can make that function to process. You have your own procurement capability. You get your paychecks every 2 weeks, I assume, Ms. Posadas? All you administrators all get paid? But the most fundamental basic sanitation that's needed at the hospital is not being addressed. We can talk about a new hospital. I'm dumbfounded that we spend so much time talking about a new hospital. I understand the facility is older, but when we can't take care of very basic day-to-day resources that are needed to keep people safe and hopefully heal them, because I don't know anybody's going to the hospital because their health is perfect. This is a total blight on this administration. I could not have conceived this politically even against this current administration. I couldn't even imagine putting this together, and you guys have managed to do it all on your own. Amazing. We had DOE here, and now we have the hospital. The priority should be to clean the mold because it's something that is a clear and imminent threat. You can go ahead and say, well, you've been here. Well, I've been here a while. I've been here longer than anybody else sitting here. But I don't take responsibility for the management of the hospital because I don't manage the hospital. The administration manages the hospital. Hospital administration, the board, manages the hospital. So I'm not going to sit here and take the hits for any of you. This administration ran on health care. And here we are, we're worse off than probably we've ever been in quite a while. I give you credit. I hope you're ready for the ramifications if you haven't experienced them already, because, well, we don't talk about these things. That's basic. I mean, yeah, I'd love to have a new building, but a new building that's going to be built in, what, 5 or 10 years? What about today with where we're at? We're not going to get probably the, I don't know if the Cadillac is anything. Is it the BMW, whatever the highest costing car is in the world that we want that model of? Maybe we can't afford it. Maybe our people can't afford it. But basic sanitation and health care and a safe, God, did we say this about DOE? A safe, clean environment? To me is the most basic, because we've heard all these stories. Wipes, sanitation wipes. I keep it in my car, in my console. The alcohol one I prefer, because I think it's going to be more safer. I don't know. But guys, this is wow. And I've been in the legislature in the midnight hour of Dr. Ed Cruz when we're borrowing money, financing money on the bond market to pay payroll at GMH. And we are no further along. If current administration cannot take care, and Lillian, you're a nurse, you know that. What are we waiting for? How much money does the governor still have sitting of ARP money that could be released to address these urgent needs? While we're waiting to build a new hospital, money that's going to expire next year in 2024. And 2024, what are we? 2.5 months away from 2024? And all we talk about, we want a new hospital. And then we want everything attached to the hospital. That's our priority when we can't get basic sanitation wipes. We can't address mold. Baking soda and vinegar can wipe mold. Oh my goodness, maybe now I'm going to have high blood pressure problems. This is inexcusable. You don't need us to tell you that. We're legislators. We set policy. We don't run operations. And I will not take responsibility for running operations unless I'm sitting on that side of the table. And I've sat at that side of the table. I know what it is to run a major operation. This is inexcusable. I don't know how you guys go to work every day and see this stuff and do nothing about it. No wonder. You think people are not wanting to work at GMH or leave GMH just because of salary? It's the working conditions, it's the politics up there that limits the ability of GMH to function, not just the money. Money's never ending. I mean, my goodness, how many payrolls at the front office have had to pull their hair out to make sure they make payroll at GMH? All this stuff that you have to wear, that's your burden. But making sure that at least if these basic things are not being taken care of, how do we take care of anything else? Are people any safer? No. Are they going to get any better health care today? No. And time is running out. 3.5 years left. And we're no better than when we were walking around the hospital, if not worse. So I don't even know where to begin here or end at this point. Because the reality of this information that's being testified today, and I have no reason to question because I give you credit. A lot of department and agency personnel, they just bide their time and pray and wait for the next administration to come in. Because they fear that they're going to get retribution or they're going to get hassled or they're going to get their jobs taken away from them for speaking up. This really...
May I, Senator?
Yes, by all means, enlighten us and the people of Guam.
Well, the
because,
wipe
wow,
situation, if I
wow.
may clarify and if I may correct you, the wipe situation was because it was clogging up our plumbing system at the hospital. It was causing a lot of problems. And we did not tell the staff to use paper towel. That was never at all my communication.
Did they
we
have
did
an
not.
alternate? Did they have an alternate to use?
I'm sorry.
Cotton ball. I used to work as a nurse, and I would clean babies' bottoms with cotton ball or hold the baby under the sink to clean that baby. You don't want to use alcohol wipes on a baby's butt because their skin is very sensitive. So yeah, but there are also washcloths that you can use to wipe, and toilet paper, but not paper towel. Paper towel is too rough. And so you don't use paper towel. I never use paper towel to wipe a patient's or a person's butt. But that was what the issue was with the wipes. And yes, we procured the wipes.
Do you have the
wipes.
wipes now? Do you have them in stock now?
Of course we have wipes now. Yes,
and then
ma'am.
what was the justification for the period of time it wasn't available? I'm sure your professional staff will know what they can
I'm sorry if I
and
may.
cannot use. Do you want to say
Yes,
something?
if I may. So we don't have toilets in the ICU. We throw them in the trash cans. And I do, Miss Lil, if you do remember I was outside one of the patients' rooms and you guys had been rounding and, I said, you asked how we were doing and I said, good, we don't have wipes. And you said, what about using toilet paper? And I said, well, that's, not really durable enough. Okay, not paper towel, but that's what we have. I mean, paper towel is a little more durable than toilet tissue. You can't really clean anybody with toilet paper because it will kind of disintegrate on their body. It's just not.
Neither here nor there. It's just the point, I'm not a physician. I'm not a medical expert. But, it's like the school system. I mean, you want to make sure that from ground central and you work your way from there. Everything closest to patient care, I would assume, is the priority. And the further away you get from that, then that's not as important. So if the crisis right now is dealing with the patient care in terms of having the resources, I asked you, Ms. Posadas, when we were having the budget hearing about what are you doing now if your vendors aren't getting paid, and you said you're working with other vendors. But, most vendors, they're in the business because they're in a business. They take the money you pay them and they buy more supplies. They want to sell more supplies. I'm sure they have overhead. I'm sure they have personnel they got to pay. And being strung along after a while, I'm sure there's a number of them that just say, you know what, no. Even though, yes, we know it's for life-saving health care needs, you can't drag, who can? Unless they're like multi-billionaires and they're just doing this to entertain themselves. They can't sustain over a period of time. And I'm saying this, guys, because when we're on the other side of the hall and our colleagues are spending money and the administration from BBMR and DOA are coming down here bragging about the incredible amount of money our government's being infused with every month, we're bragging about the most recent, $56 million. Senator, what are your thoughts on that? And this is the state of where we are at an area that everyone would say next to public safety, education, number 3 priority, which never changes, is health care. Maybe you don't see it, but from my side of the table, I mean, I see it. I think a lot of people out there watching or who are currently up at the hospital or have family members up at the hospital see it. And this is disturbing. I'm not going to go on, right? I have to go take a break, you know, because, again, I got to get my chill pill.
Senator Brown, may I just make a point of clarification regarding the mold? The mold that we're looking for is hidden. It's behind, possibly behind drywalls or not. It's possibly in the ducting system or not. You're not going to take baking soda and water to inside these systems. We're removing mold on ceiling tiles. We do it every day. We remove it on the walls, but that's not what we're looking for. We want to know the magnitude of the situation, and that's why we had to hire specialists.
I understand, but how quickly are you moving to do this? I don't think the mold just appeared yesterday. I'm sure it's been there for a while. It's just feeling a sense of urgency and priority. Sometimes we know everything can't get done right away, but if I feel that they're on it, okay, we can manage. But if you just feel like maybe we'll get around to it, and I'm sure your air conditioning system isn't improving the situation, it's probably multiplying it more. And I'm no mold expert either. I'm just saying there's a disconnect here because, I mean, I don't feel your people need to come here to tell us the issues of concern they have with you. You're the administrators. You should be communicating and working with your people and addressing their key concerns because we can't do it. We're not the arms and legs of the administration. We don't have the authority to do it. We set policy. We don't manage and operate. You wanted to add something?
If I can, I'm reading from NIH, Moisture and Mold Remediation Plan. There's a Standard Operating Procedures 2023. The very first thing it tells you is you cannot use those blowers that we're using right now, like in ICU, those HEMA fans. You are stirring the mold and you're stirring the spores up. It clearly states it right here, this is 2023. It's the standard of operating procedures for controlling mold coming from the NIH. Thank you.
Thank you for your input. Madam Speaker, I'm going to move to other colleagues, and I'm going to take a break for a while, but I think I've made my point. I just see a major, and it is, I mean, I hope the governor, you know, I know she's going through a challenging time with the passing of her mother, but I have to tell you, this coming forth, and the fact that we're no better along, if not in some cases worse, is disturbing. And I hope you guys do something soon to address, because these are your people. These are not our people. These are your people coming here publicly and making these statements. And I'm sure for them, that's the reality. They work there. I don't work at GMH. We don't work at GMH. We might know people. We have family members and friends that work up there who, you guys tell us one thing and they tell us other things. But basic maintenance and operation, typhoon or no typhoon, we've been through many. This is not the first, maybe it's been the first in a while, but it's not the first we've been through that we haven't been able to still juggle with the things that need to be repaired, but still be able to carry the load and do what we need to do. We can talk about all these big grand plans, but I'll tell you, if we can't take care of the basic needs that are needed there, and I don't care whether it's an alcohol wipe or non-alcohol wipe or whatever it is you guys determine is the best medical supply to use, I defer to you. But if that's not even available to your medical staff, and they're complaining about it, and the reason we're not doing it is because we're clogging up the sewer line, I don't know. I don't buy it. I don't buy it. Thank you, Madam Speaker.
Thank you, Senator Brown. Senator Taitigui.
Thank you, Madam Speaker. Lillian, do you feel that there's a major issue at the hospital right now?
There are many issues at the hospital, and we are trying to address it as quickly and as practically and reasonably as we can within our resources.
Is it almost like almost getting to a point of a state of emergency?
Truthfully, Senator, we can just close that hospital down.
Okay, so that being said,
But we
Lillian,
can't.
what can you tell me when you, because just didn't happen yesterday, okay? No, it didn't. So it's been going on, and you've been sitting in there for 5 years almost at the same hospital, and it's gotten worse. So when you went to the governor and told her that this hospital is in a state of emergency, what did the governor say to you?
She will help as much as she can, and she has. She has provided us with the support, and she has provided us with some funding. But you know what? Maybe in some way, some people see it as worse, but there's also some improvements. So I don't like that we continue to focus on the negative part of it. Yes, we face the problems, and we deal with it.
But
to
Lillian, I'm
continue with
sorry,
that mindset of
it is all
negativism-
negative.
Sorry, one at a time, please.
Yeah, but it is all negative, Lillian. You know, first I want to thank the 2 nurses who came here today and put themselves on the line, had the courage to come up here to tell us what's going on and not be afraid and do it in front of the administration. So I want to thank you for doing that and having that courage to be here today and letting us know your perspective. I mean, you're there in the trenches. But Lillian, you've been there for 5 years and it's only getting worse. Isn't there a time for you to say, okay, I can't do it, I need to step down from this job and allow somebody else to come in to try and help this
Well,
hospital?
You know, Senator, thank you for that idea. Yes, I will step down. Yes, I will retire. I've done my time. Thank you.
Thank you, Lillian. That being said, Madam Speaker, I think, you know, if that's the
Madam
case, then
Speaker, may I be excused, please?
I guess
can't
we
take
had
it.
the
We're going to take a
administrator
5-minute,
just
we're going to take a
present.
5-minute recess. 5-minute recess. Thank you. We're back from recess. Thank you for your patience. Again, just to recap, we are in the middle of an oversight hearing on the Guam Memorial Hospital on several issues, some of them very long-standing, including the HVAC, some of them new, including the billing issues, the backlog in vendor payments, and it has become yes, it's been hard because there aren't any very real solutions for some of these problems that are on the table at this point. And so I've discussed this with my colleagues, and we are going to recess this oversight hearing. Yes, and also at the request of the administration of Guam Memorial Hospital, they would like to regroup. So I want to thank all of you who have come today to testify. I want to thank the Guam Memorial Hospital for all their work, everyone. And in fact, we did see some good things. In fact, the billing has improved, so we've got much more billings than what was reported to us in July. But we still do have some very serious issues. So again, thank you all, and thanks to the Guam Memorial Hospital, all of those people who are working there under some very serious conditions and very trying times. And thank you from all of us, from all of my colleagues. Thank you for your work, your continued work, all of our continued care, your continued care for the people of Guam. And that's, I know, why we're all here, all of us, everyone working at GMH, and all of you who've come to testify. So Sidzus Masi. And thank you to the public who have sent in to me testimony and concerns that they wanted me to raise at this hearing. And so we're going to adjourn this hearing for now, and we will reconsider what we're going to do going forward. Sidzus Masi. It's right now, we're going to adjourn, 4:30 p.m. Thank you. This is adjourned.